we know that conventional biventricular pacing remains the gold standard treatment for patients with ischemic or non-ischemic cardiomyopathy and wide QRS. But we know that at least one-third of the patients are non-responders and lead dislodgements in at least 2.9 to 10.6%, poor venous anatomy, procedural difficulty, high thresholds, phrenic nerve captures. So all these difficulties are there. So I can say at least one-third of the patients may not be salvaged by conventional biv pacing. So there came the conduction system pacing as a rescue strategy. So what is the concept? So we are talking about conduction system pacing, but what exactly is the concept of doing conduction system pacing as an alternative for CRT? So the fibers inside the His bundle are longitudinally dissociated. So some fibers will go predominantly into the left bundle and some fibers will go predominantly into the right bundle. For example, if you have disease in the red colored fibers, the patient will have left bundle branch block morphology in the ECG. And if you have disease in the yellow colored fibers, the patient will have right bundle branch morphology in the surface ECG. So associated with LV dysfunction, if you are going to deploy the lead just distal to the site of block, either in the distal His bundle or in the proximal left bundle, you are going to regenerate the normal appearing QRS because you are pacing just distal to the site of block. So that is going to resynchronize the ventricle in a much, much better way as compared to biv pacing. Of course, the procedural aspect I'm not going to talk because we already discussed it a couple of days back. So here, to put it in a nutshell, we are going to deploy the lead in the proximal interventricular septum in the left bundle branch area. So the anatomical zone will be 1.5 centimeter below the tricuspid leaflet in the proximal septum. You have to drill the lead deep inside the septum to reach the LV subendocardium to capture the left bundle fibers. Of course, I'm going to discuss in two different scenarios. One is CRT by LVBP as good as CRT by a biv pacing. So let us take an example. So this is a typical example of a non-ischemic cardiomyopathy, left bundle branch block, normal coronaries, severe LV dysfunction. So you can see the ECG showing a typical LVBP fitting into the Strauss criteria. So all you have to do is just take the lead distal to the site of block, deploy it in the proximal left bundle zone. You'll be able to regenerate a almost near normal appearing QRS. The hallmark of left bundle branch pacing is right bundle branch block conduction delay because you are pre-exciting the left bundle. So that can be masked by adjusting the AV delay, adjusting the output to get the anodal capture, but there are several ways of masking it. So this will actually regenerate almost normal appearing QRS. Needless to say, once you regenerate a normal appearing QRS, you'll be able to resynchronize the ventricle, you'll be able to improve the LV ejection fraction. This is what we have shown in our first international LVBP collaborative study group. This was a late breaker in 2020, and we could show that patients with an LVBP morphology as well as non-LV morphology, they have significant reduction in QRS duration, significant improvement in LV ejection fraction, significant improvement in NYHA functional class 2. So this is irrespective of the underlying QRS morphology. But the patients with an LVBP, they responded with a much, much better way as compared to those with a non-LV morphology. This is an important study to note by Dr. Huang, who is considered as the father of left bundle pacing. You can see a red circle there. 75% of the patient, they have an EF of more than 50% at the end of 12 months. The patients selected were non-ischemic cardiomyopathy, left bundle branch block, fitting into typical Strauss criteria. The success rate was very high, it was more than 95%. But the more important thing to note is 75% as normalization of the LV function at the end of 12 months. This can never be seen with conventional biv pacing. This is our own data, so we have gathered the patients with left bundle branch block induced cardiomyopathy. So where LVBP alone is the culprit, so we have followed the patient. They had LVBP with normal LV function to begin with. Over a few years, they had deterioration. So they had worsening of LV function. We intervened by doing a left bundle branch pacing. We normalized the QRS. What we could show was there was a 100% hyper response. So when LVBP alone is the culprit, intervening them at an early stage, you are going to regenerate the heart in a better way. Of course, we have two landmark randomized trials which got released recently in the last couple of months. So one is conduction level 80 trial, which showed that the left bundle branch pacing is non-inferior to conventional biv pacing, and the next one shows that the left bundle branch pacing is superior to conventional biv pacing. Remember, both these are randomized trials. The only issue is both of them involve very small number of patients. Coming to the second strategy, CRT by LVBP better than biv therapy. Remember, there is no head-to-head trial comparison available. Electrical resynchronization. Just see here, this is conventional left bundle branch block in a patient where RB is getting activated first, followed by left ventricle. That too, the activation is from distal to proximal. So once you do left bundle pacing, you can see the left ventricle will be activated from the lead tip, which is right on the top of the left bundle. So that will be like a near normal activation. You'll have a sequential activation of the vesicles, left ventricle, then followed by the right ventricle. So this sort of electrical resynchronization can never happen with the BIV therapy, which is after all a myocardial pacing. Of course, for those patients who had a non-LBBP morphology, for example, right bundle branch morphology, this was our second of international LBBP collaborative study group data, where we have shown that still in patients with an RBBP, we could reduce the QRS, but not as much as in patients with a baseline LBBP, but they still showed improvement in LV function and reduction in LV dimension. Functional mitral regurgitation. So I have looked into a lot of data in the internet while preparing this paper. What I could see was maximum there was a 40% reduction in functional mitral regurgitation in patients who are undergoing a conventional BIV therapy. But for us, we could get almost 82% reduction in functional mitral regurgitation. So this was a patient's echo which was taken just 10 days apart. So this was before procedure, this was after procedure. Within 10 days, you could see how beautifully the functional mitral regurgitation has come down. So almost 82% of the patient, they have responded beautifully to left bundle branch pacing. This is much, much higher, almost double as compared to those patients who have a conventional BIV pacing. Electrical resynchronization, so we don't do much optimization. We don't play much with an echo, we just do an AV optimization. You could see how beautifully the septum and the lateral wall is contracting synchronously. Pacing-induced cardiomyopathy, all you have to do is remove the old RV lead, put a left bundle lead, use the same dual chamber pacemaker. Pediatric CRTs, we know that CRTs are not easily performed in a pediatric age group. So there was a lady in Kolkata where transplant was listed for a pacing-induced cardiomyopathy. We attempted left bundle branch pacing at a desperate matter. We could show that improvement in LV ejection fraction from 17% to 31%. The baby was taken out of the transplant leads. AVJ ablation, this strategy is going up rapidly after the advent of conduction system pacing, be it conventional his bundle pacing or a left bundle branch pacing. But the advantage of left bundle pacing is you can perform AVJ ablation much, much comfortably because your pacing lead is distal to the site of the ablation. Not all QRS will be reduced by doing a left bundle pacing. I'm not optimistic in getting 100% response. So at least in 85% of cardiomyopathy patient, you will have a normalization of the QRS. Rest 15%, you have to go for what is known as left bundle branch optimized cardiac resynchronization therapy, where you have to get the help of your friend coronary sinus lead. So this particular patient had a wide LBPV. There was an incomplete correction by left bundle branch pacing. I put one more CS lead. I could regenerate a good appearing QRS. This patient responded well. So you cannot see that the CS lead as an enemy. You have to get the help of the CS lead and complete the procedure as a lot CRT. In fact, we had gathered the data. This was our third international LBBP collaborative study group data, which showed that this lot CRT is much, much better as compared to a conventional BIV CRT. Rescue left bundle branch pacing. So these are the patients, this was our fourth data, where those patients who had failed the conventional CS lead or whom there was a procedural difficulty because of poor venous anatomy, we have gathered the data. We could show that even in patients who had a failed CRT, either a non-responders or a poor CS anatomy, there was an improvement in after performing left bundle branch pacing. So advantages, we have performed a single lead CRT in a patient with an AF LBBB, just ablate the AV node, put a single lead, dual lead CRT in all non-ischemic cardiomyopathy patient, triple lead CRT in those patients where there is a partial correction, and quadruple lead CRTD in patients who requires a conventional ICD lead. ESC guidelines, there was a little disappointment with an ESC guidelines in 2021. They say they have priced the left bundle pacing, but they said they are not going to give a status as of now because of lack of evidence. But future seems to be better. They have mentioned with the increasing adoption of the technology and with the availability of randomized trial, most probably this left bundle pacing will come into the guidelines. That is what we are seeing. At least dozen of randomized trials are already in, and this was the latest EHRA survey published last month in Europe, where they have shown that it is anticipated that CSP, mainly left bundle branch area pacing, will predominate over the conventional RV pacing and BIV pacing in future. So definitely the future seems to be better. So it's our strategy. So we'll go for a conduction system pacing with the dual chamber pacer, if feasible, in patients with an AV block and LVEF less than 50%, typical block HF group. Non-ischemic cardiomyopathy with a wide QRS, provided there is a limited scar. Pacing-induced cardiomyopathy, where you can still use the same pulsar. AVJ ablation, you just have to perform the AVJ and put the lead, or put the lead and perform the AVJ. That's our strategy. Pediatric CRTs, data is lacking, but still putting a single lead is much, much better than putting 3 leads. Of course, in those patients where you cannot narrow down the QRS, we have the help of CS lead. We can perform hot, his bundle optimized or left bundle optimized CRT for patients with ischemic cardiomyopathy, IVCD, non-LBBB morphology, and those patients were NICM with a suboptimal QRS correction. Let's keep our hope and faith on conduction system pacing. Thank you for your patient listening.